Last lecture, we talked about the chronic non-infectious causes of the diarrhea. Today's will mainly focus on the infectious causes of the diarrhea, and most more focus will be on the acute presentations. So any diarrhea which is acute onset, less than 2 weeks in duration, is treated as infection unless the infection is either excluded by cultures and all the relevant investigations, or infection is being treated. This rule will also apply even if the patient is known to have a clinical condition which can present acutely with the diarrhea, such as if the patient has ulcerative colitis and they present with the diarrhea duration is less than 2 weeks, we will still consider infection on the top and ulcerative colitis will come as a second. This is a rule. So today we will mainly focus on the acute infectious causes of the diarrhea, and I'll try to cover as many as possible out of them. So the first thing is infection can cause diarrhea by following mechanism. One is toxin mediated gut diarrhea. Toxin has two ways to cause diarrhea. One are the secretory toxin, which causes increased secretions of the gastric intestinal glands and cause diarrhea. And secondly, the bacteria, they can, second mechanism is that bacterial toxin can cause physical damage to the mucosa of the colon and they can cause diarrhea, okay? Toxin mediated colitis. And the third is the bacteria itself invades the colon or the intestinal mucosa and cause diarrhea. And the right, so these are the three levels. One is toxins, which doesn't damage the wall, and they just causes increased secretions of the intestinal glands and cause diarrhea. This is one mechanism. Second is toxin mediated necrosis of the mucosa. Third is a bacterial invasion causing damage to the intestinal wall. And fourth is the next step, that bacteria invade the wall, plus they also enter into the blood. So these are we can categorize the acute infections into four main mechanisms, okay? We'll talk first about the toxins. So the toxins can be of two types. One is a preformed toxin, which is also called as food poisoning, that the patient has ate a food which already has a toxins produced by the bacteria present in the food. So in that cases, the person actually ingests the preformed toxins. Okay. So these toxins, they can go and cause secretions and they can cause diarrhea, or they can alter the gut functions, right? So few of those toxins are heat stable toxin. Remember, S for stable, S for stomach. The heat stable toxin, they affect more on the stomach. They causes vomiting more than the diarrhea. Other toxins are the heat labile toxin. They remember L for labile, L for lower gut. Labile toxins affect more on the lower gut, which is colon. So labile toxin causes diarrhea more than vomiting. So heat stable toxin, stable, causes stomach irritation more and causes vomiting more than diarrhea. Whereas heat labile toxin causes colonic irritation more and causes diarrhea more than vomiting. Okay. Classically, the food poisoning, which is due to the preformed toxin, is very important to differentiate because the management is different. The preformed toxin means the person is ingesting a fixed amount of the toxins. And when the patient starts vomiting or having diarrhea, that toxin will be flushed away. So these toxins usually are washed out of the gut within next 24 hours. And because the toxin is preformed, so the symptoms start very quickly. So classically, if it's toxin mediated food poisoning, the symptoms usually start within 6 hours of the ingestion of the food, and they finish they improve a lot within 24 hours after the ingestion. So classically, between 6 to 24 hours after the ingestion of the food, the things are over. This is preformed toxins. Because it's caused by the toxin, not by the bacteria itself, there's no bacteria causing intestinal damage. So these patients, they don't need any antibiotic. Okay. So this is important to differentiate preformed toxin mediated gut irritation causing diarrhea or the vomiting usually starts within 6 hours, improves within 24 hours, and doesn't need antibiotic. All it needs is symptomatic management with the hydration and symptom control. Okay. And that can happen with the staph aureus. Remember, S for staph, S for stable, and S for stomach. Staph food poisoning usually causes stomach irritation more than colon irritation. So staph food poisoning causes vomiting more than the diarrhea, and it produces heat stable toxin. Bacillus cereus and E. coli, they usually produce labile toxin. Same it goes with the Vibrio cholera. They produces heat labile toxin. Okay, and they cause diarrhea more than uh, vomiting, right? So this is about the preformed toxin. Then the next is that we ingest the bacteria. Bacteria goes in the intestine and they produce toxin while sitting there. Okay, bacteria are not invading the intestine, but they are producing toxin while sitting in the intestine. So as long as the bacteria are there, they will keep producing the toxins, and the symptom will go beyond 24 hours. So toxin mediated food poisoning, if it settles within 24 hours, that is preformed toxin. If it continues beyond 24 hours, then it's the bacteria which has been ingested and that's causing the symptoms. Okay, most of the other bacteria, if they cause toxin mediated poisoning such as Vibrio cholera and Bacillus cereus, they 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 fit in the second mechanism. Okay, Vibrio cholera, when it's ingested, it continuously keep on producing heat labile toxin and causes ongoing diarrhea which goes beyond 24 hours. But these bacteria, they are not causing damage to the intestinal wall. Okay, so there will be absence of the clinical clues which indicate that there's a damage to the intestinal wall. I'll come to that in a minute. The third mechanism of the bacteria is the bacteria itself is causing infection there. Beyond the toxin, bacteria is causing infection there. And of course, when the bacteria is causing infection, bacteria will also produce toxins as well, which will cause cytotoxicity, but the bacteria itself is also invading the mucosa. Okay. And most of these infectious diarrheas, they are due to the third category, which come to our clinical attention. Because usually the food poisoning will settle down in 24 hours. So we often don't see them in the clinics or in the medical floor. Okay? They settle within 24 hours. Out of these bacteria, the main bacteria which causes acute problem is E. coli. Okay, E. coli is one of the major bug which will cause these problems. Okay, now E. coli is very generous in a way that it shares all its genetic material with other bacteria. There's a saying, any bacteria who lives with E. coli start behaving like E. coli because of the genetic sharing. Give you an example. Enterococcus is a Streptococcus faecalis, is a gram-positive cocci. It lives in the colon, but it behaves like E. coli. Although it's a gram-positive cocci, but it behaves like E. coli. So any bacteria which start living with E. coli, because of the sharing, it causes it behave like E. coli. So E. coli is the main culprit which we need to focus. E. coli is also very good recipient as well. It also receives many genes shared by the other bacteria. To give you an example, Shigella produces Shiga toxin, and E. coli can share the genetic material with the Shigella. So E. coli can also produce Shiga toxin. So this is how E. coli shares its genetic material with many other bacteria. Okay. So E. coli, when it causes diarrhea, mainly because we're focusing on the diarrhea, so I'll stay mainly on the diarrhea. It causes three mechanisms. Again, the same thing is a prototype bacteria. It will use all the available mechanism which we have already discussed. It will produce toxins, it will produce cytotoxins, it will invade the mucosa itself, and it can also enter into the blood. Okay, so E. coli, which produces just toxin mediated enterotoxigenic E. coli, will cause diarrhea, but it doesn't usually damage the intestinal wall. Okay, doesn't usually damage the colonic wall. The common site of the infection with these bacteria is often the terminal part of the ileum and the right-sided colon. Most of the time, these bacteria, E. coli especially, causes infection in this part, but certainly it can involve the whole colon as well. It's less common for these bacteria to cause infection in the small intestine because of the many reasons. Because of the bile salts, they kill the bacteria. So bacteria don't usually settle in the small intestine. They are less likely to cause infection in the small intestine. Okay. Second is the ongoing motility of the small intestine, which doesn't let them stay. Okay. And third is the pancreatic enzymes. So all these things, they make the small intestine little bit more resistant to the settlement of these bacteria and causing infection there. So they mainly infect colon. Okay, so E. coli is the cytotoxigenic one will cause invasion. One is enterotoxigenic, which just produce non-invasive toxin. The second is toxigenic, which causes necrosis of the mucosal wall. Whenever there's a damage to the mucosa of the colon, there will be few clinical indicators, and these are important indicators because they are the main reason when we start antibiotic for any patient with infectious diarrhea. Okay, one of them is abdominal pain. So whenever there's a damage to the intestinal mucosa or the wall, there may be abdominal pain. It could be continuous pain or crampy pain, or crampy on top of the continuous pain. Okay. Second is presence of the blood in the stool. Okay. Third is presence of the white cells in the stool. Fourth is abdominal tenderness. On examination, the patient can be tender along the colonic wall, right side, right paracolic gutter, transverse colon, or the left paracolic gutter, or the sigmoid area. The patient can be tender in those areas. Okay. The fifth is presence of the systemic inflammatory clues, such as the patient start having fever, patients start having high CRP and white cell counts. So these are the parameters that there's intestinal damage. And of course, if you do the abdominal imaging, such as CT abdomen or the other investigation, they can show the mucosal edema or thickening of the bowel wall, or other changes of the infection, such as mesenteric fat stranding and stuff like that. Usually, the mesenteric fat stranding mean the infection is sitting either transmural or is on the outer side of the wall. Okay. So, but sometimes, even despite the infections causing damage, if the damage is limited to the mucosa, CT may not pick it. This is important point. So CT may miss it if the damage is limited to the mucosa. CT is usually good when the infection is transmural. Okay. So mucosal infection are not usually commonly detected by the CT scan. They may be missed. The CT may be normal. Okay. So I will just summarize the clues. One is abdominal pain, abdominal tenderness, blood in the stool, white cells in the stool, systemic inflammatory markers, white cells and CRP or procalcitonin, and fever. These are the clues which mean that there's a damage going on, and we often need the antibiotic for these patients. So enterocytotoxigenic E. coli or enteroinvasive E. coli will cause colitis, will cause damage to the colon, and will have usually some of these manifestations. Okay. We're still on the E. coli. I'll spend few minutes more on the E. coli. Uh, As I said before, the E. coli, because it has the ability for the genetic sharing, it can also produce a Shigella toxin. So E. coli and the Shigella, because they produce Shiga-like toxins, so that toxin can cause problems such as hemolytic uremic syndrome. So these patients can have a complex clinical course complicated by the renal failure and complicated by hemolysis and uremia. Okay, and encephalopathy. Patient with the diarrhea and patient with these gut symptoms, vomiting, diarrhea, because they're not eating well and they're losing fluid, they can have a renal failure as well because of the dehydration. So we need to differentiate this one from the uremia or the renal failure which happen in the hemolytic uremic syndrome. So patient with the renal failure due to the dehydration is a pre-renal. Okay, glomerulus is normal, tubules are normal. It just when we give the fluid, it responds well. Whereas the patients with the hemolytic uremic syndrome actually have a microthrombi inside the glomerular and causes tubular ischemia and glomerular ischemia. So there's an element of glomerular damage. So patient may have glomerular hematuria or proteinuria, and it usually doesn't settle with the fluid replacement. Okay. Unlike the pre-renal renal failure, which happens because of the dehydration. So often the patients who have got acute infection, if they go into the acute renal failure, if the urea creatinine start rising, or they have anemia, or they start going uremic, we need to keep in mind hemolytic uremic syndrome, and the most likely culprit is either E. coli or it could be Shigella, right? So that is about the E. coli. The next common acute bacteria is a Shigella, right? Shigella, one of the is more like a E. coli. It behaves like E. coli, but the one of the important finding we need to remember about the Shigella is an immotile bacteria. It doesn't move much. So what it does is it lies on the mucosa and produces cytotoxins, Shiga toxins, okay, and which causes necrosis. Because it doesn't cause it's a very immotile bacteria. So bacteremia is very rare in Shigella, whereas bacteremia is quite common with the E. coli. So E. coli can cause gram-negative bacteremia, whereas Shigella doesn't. Okay. Otherwise, the infection of the Shigella is also mostly on the in the colon, and it causes acute colitis. And usually it can because of the necrosis caused by the Shiga toxin. Usually there's a bleeding as well, so which is called as dysentery. Okay, blood containing stool. But absence of blood doesn't exclude Shigella, right? Usually the treatment is same for both. Now, the third bacteria which we need to remember is Salmonella. Now, Salmonella, there are 3, 4 serotypes. The common Salmonella we deal with in the clinical cases is Salmonella typhi, which causes enteric fever. Okay, this is one. Second is a Salmonella paratyphi, and the third is a Salmonella intratides, and fourth is a Salmonella suis, S-U-I-S, Suis. Okay, out of these, Salmonella typhi, which causes enteric fever, and Salmonella paratyphi, which causes paratyphoid fever, they usually doesn't cause damage to the ileum in the first week of the infection. They come through the oral route. They first grow in the tonsils, then they grow in the ileum. But when they grow in the ileum, they don't cause damage to the ileum. Okay, they usually cause little bit swelling of the Peyer's patches, which can narrow the ileal mucosa, and that can cause mild constipation, if anything. Right? Otherwise, Salmonella typhi in the first week doesn't give you any gut symptom. Presence of the GI symptom in the first week of infection is usually against the diagnosis of Salmonella typhi. So, which Salmonella affects intestine is the Salmonella intratides. Okay, Salmonella intratides is the one which comes from the poultry and the chicken. Salmonella typhi, the only source is the human. Okay, so Salmonella intratides, which causes gastroenteritis, which causes colitis, or which causes ileitis, usually comes from the poultry and is different from the Salmonella which cause typhoid fever. So Salmonella, when it infect gut, it has to be Salmonella intratides, not the Salmonella typhi. So I would repeat it because this is a very important point. If you're dealing with a patient who is presenting with the febrile illness, okay, and there are gut symptom right from the beginning, or their gut symptom in the first 2 or 3 days or 4 days of the infection, it's very unlikely to be a Salmonella typhi. If it's a Salmonella, it's more likely to be a Salmonella intratides. And Salmonella intratides is the one which doesn't cause enteric fever, it causes gastroenteritis. It causes colitis basically. So this is very important. Okay. Another important point you need to remember about the Salmonella, otherwise it's same like E. coli. They're not much different, but there are only few different points which I'm trying to highlight. Other important point of Salmonella intratides is antibiotic use in cases of Salmonella intratides is usually not recommended unless there is a severe damage caused to the colon, because it prolongs the shedding of the bacteria. So if there's no significant intestinal wall damage, and we isolate Salmonella intratides in the stool culture, we often don't need to give the antibiotic to these patients. Yes, we give antibiotic if there are clinical clues of damage to the colon. So I think that point is clear. So that's about the Salmonella. Okay. Now some of the bacteria, they can affect, they can cause diarrhea even if they're not in the intestine, even if they're not physically there. Okay. For example, Staph aureus sitting anywhere in the body can cause diarrhea and can upset the stomach. So, for example, patient has endocarditis, or patient has staph osteomyelitis, or staph abscesses in the skin, or patient has toxic shock syndrome toxin because of the staph. So, wherever this is the staph, if it produces toxemia, it throws toxin in the blood, they can cause diarrhea even if the infection is not there physically. Similarly, atypical bacteria, they when they cause infection in the lung, they can also infect the gut as well. So they can cause diarrhea as a part of the systemic response. Okay. Now, few more bacteria which are not very commonly thought and they're not very commonly encountered are the one which cause acute ileitis. Okay. The question which was asked in the beginning was about the acute ileitis. So I will focus mainly from the infection point of view. Okay, so there's some bacteria which can cause acute or chronic ileitis. They usually start with acute ileitis, and then it prolongs with the it can prolong to the chronic phase. So those are the one which are important. One is a Yersinia enterocolitica, Yersinia pseudotuberculosis, and the third is Campylobacter jejuni. Okay, so these are the bacteria which can cause acute ileitis or they can cause chronic ileitis. So they can have a findings of ileitis, acute ileitis. Okay, so usually because the ileum is a mid-gut derivatives, so they often cause periumbilical or mid-abdominal pain, which can be confused with the pancreatitis. Remember, pancreas has two parts, upper half and lower half. Upper half is a derivative of the foregut, which is stomach and the gallbladder, and the lower half is derivative of the midgut. So when the lower half of the pancreas is damaged, usually it presents with the midgut pain, which is periumbilical pain, and the ileum is also midgut derivative. So sometimes acute ileitis can be confused with acute pancreatitis as well, because it can present with a periumbilical pain, and the pain can be very non-specific, and the diarrhea may not be there in the beginning. And often when there's acute ileitis, if if the thickening of the ileum is significant, it can actually block the lumen or narrow down the lumen to the point that there's not much flow there. So rather than causing diarrhea, it can just present with either constipation, or it can present with small bowel partial or complete obstruction type picture. Okay, because pancreatitis also causes constipation, and the mechanism is because the transverse colon runs in front of the pancreas. The mesentery of the transverse colon is attached to the front of the pancreas. Okay, so pancreatitis causes collapse of the transverse colon. Similarly, pancreatitis uh, pancreas is surrounded by the duodenum. So pancreatitis also causes paralysis of the duodenum. So because of the paralysis of the duodenum and the transverse colon, pancreatitis often causes diarrhea. I'll take a break. Right. So back to the point, when there's acute ileitis, it can be confused with acute pancreatitis as well, because they both can cause periumbilical pain, and they both can cause constipation as well. Okay, but acute ileitis often causes diarrhea. Constipation is less common, but it can cause diarrhea because of the bile salt malabsorption, which we discussed last time, right? So bacteria which can cause acute ileitis, the commonly is Campylobacter and Yersinia. Yersinia are different types, but they can cause. Okay, and they can also go into the chronic phase. So if the patient is not having findings of acute colitis, but there's a rather acute ileitis, then you need to think about Campylobacter and Yersinia, or the Salmonella more than E. coli. Okay, so among the acute infection, we can divide the common bacteria based on the location of the acute infection. If the acute infection is affecting the small intestine, causing malabsorptive diarrhea, which happens in small intestinal bacterial overgrowth. Okay, the second is Giardia lamblia can also causes acute infection of the small intestine. So they both, Giardia lamblia and small intestinal bacterial overgrowth, they are then acute infection which can present with the malabsorptive diarrhea. Acute ileitis, which usually is a Campylobacter or Yersinia, or it could be Salmonella. Acute colitis all the other gram-negative bacteria such as E. coli and Shigella and those other bacteria which cause infection of the colon more. So remember, from the location point of view, if the diarrhea is less than 2 weeks and is more like a malabsorption pattern rather than colitis pattern, you think about giardiasis and you think about small intestinal bacterial overgrowth. If it's more like acute ileitis-like pattern, I'm not going into the detail of the ileal manifestation because we have discussed in the previous lecture. So if the manifestation is more like acute ileitis type picture, periumbilical pain, tenderness in the right iliac fossa or in the periumbilical area, early constipation followed by the diarrhea, watery diarrhea, okay, ileal thickening and all those things. Okay, so then you need to keep in mind Yersinia, Campylobacter jejuni, and Salmonella enteritis. And if the acute diarrhea is mainly because of the colon, like acute colitis-like picture, then you think about E. coli, Shigella, and other gram-negative bacteria. Okay. Similar to the bacteria, Entamoeba histolytica, which is amoebiasis, as you all know, also causes acute or the chronic infections. Okay. In the acute phase, it commonly affects right side of the colon, cecum and right-sided colon. Okay, so amoebic colitis or amoebic typhlitis. The infection of the cecum is called as typhlitis. Typhlitis, typhlitis. Okay, and the classic finding is because the cecum is very thin-walled, it gets dilated, and because of the fluid pooling, if you press in the right iliac fossa, there's a gurgling sound. So that is a classic sign of acute typhlitis. Okay, amoebiasis is notorious to cause acute typhlitis, amoebic typhlitis. Okay, which is cecal infection, right? So it presents with acute watery diarrhea, which may be mixed with the blood, and there might be typhlitis as well. So classically, acute amoebiasis involve the right side of the colon. It can go into the chronic phase. We'll come to the chronic causes of the infection, and then it will come again. But it can present with acute as well. So commonly, acute amoebiasis confuses with the bacteria which involve the colon more, such as E. coli and Shigella, rather than confusing with the giardiasis or confusing with the bacterial overgrowth. I hope now onward it will be very clear that if the patient has acute diarrhea less than 2 weeks and it's more like a malabsorptive pattern, okay, you think about small intestinal bacterial overgrowth, especially in the patient who are at the risk factors such as scleroderma, diabetic autonomic neuropathy, patient with upper GI surgeries with a blind loops and those stuff, and diverticulas, okay, or it could be a giardiasis as well. Okay, if it's more like acute ileitis, Yersinia, Campylobacter, and Salmonella enteritis, they favor more like acute ileitis. And rest of the bacteria, E. coli, Shigella, other gram-negative bacteria, and amoebiasis, they involve colon more. So this is more like you can have some clinical guess that which organism should I focus more, okay, right? There's no point focusing on E. coli if it's fitting with the acute malabsorptive pattern. And there's no point for thinking about giardiasis if the patient is presenting with acute colitis. So they are the different, okay? And there's no point thinking any of these if the diarrhea settled within 24 hours from the onset and it started within 6 hours of the food ingestion. So I hope that probably gives you some idea about how to think about which bacteria or the organism in cases with acute diarrhea. Now coming with the chronic infections, many a time we deal with the patients who have diarrhea which is more than 2 weeks, and we need to think about the infections as a possibility. Although the non-infectious etiologies which were discussed in the last lecture, they come into play as well, but still there are infections. So among the infection which can goes into the chronic phase is the one which grows in the small intestine, such as bacterial overgrowth and giardiasis. Often when they are not treated properly or they're delayed diagnosis, that can enter into the chronic phase. So they can present with a chronic malabsorption like pattern. Okay. In the phase of the chronic malabsorption, if the chronic malabsorption is because of bile biliary system, then you also need to think about the biliary parasites, Clonostrus, and those flukes, okay, which can block the bile duct. They are infections, so that's why I'm mentioning them. So they block the bile ducts and they can cause uh, bile salt induced malabsorption. Bile salt, because of the deficiency of the bile salt, they present with the malabsorption. Okay, patient may have a obstructive jaundice as well. So they are called liver flukes. Okay, but if the acute, if the malabsorption is chronic, and we think about the infection, the small intestinal bacterial overgrowth and chronic giardiasis are also the possibility which we need to keep in mind. On top of that, Whipple's disease will also enter into the list then. We discussed about the Whipple disease a little bit in the last lecture, so I won't go into much detail. But Whipple disease also presents with the chronic malabsorptive diarrhea. Okay, so infectious causes of chronic malabsorption include liver flukes from the biliary system and small intestinal bacterial overgrowth, chronic giardiasis, and the Whipple disease. Out of these, Whipple disease after, because it's intramural, it's inside the wall, so it causes mucosal thickening and edema, and it may damage the mucosa as well. Whereas the giardia, it just lies over the mucosa and it doesn't cause any physical damage. It just causes coating of the mucosa and causes diarrhea. Okay, so these are the chronic malabsorptive diarrhea, but because of the infection. Chronic ileitis, again the same organisms. Yersinia can enter into the chronic phase often because because of the delayed diagnosis, because they are not very common and they are not commonly thought about. So because of the delayed diagnosis, although they start as acute infection, but they are often enter into the chronic phase as well. So chronic infection due to Yersinia or Campylobacter, they're not uncommon. Okay. Now, among the chronic infection, we are at the level of the ileum at the moment. Okay. Among the chronic infection, of course, the TB will also be added now. Okay. TB is very uncommon to cause acute ileitis, but when there's a chronic ileitis, certainly TB is among the infection. TB comes on the top. And if you're working in the countries like us, in the developing countries, then TB is always number one if it's a chronic ileal disease. Okay. So at the level of chronic ileum, if it's a chronic ileal diarrhea because of the infection, then TB, Yersinia, Campylobacter. These are the main ones. Okay. And in the colon, usually the chronic colitis is most of the time is non-infectious. Immune system contains the infections, but amoebiasis can enter into the chronic phase, and it can present with the chronic right-sided colitis. Okay. These are mainly the chronic organisms. So I hope now the organism can be stratified based on the anatomical location as well. Patients who are immunocompromised patients, or patients such as patient who had a uh, metastatic cancer, the patients who are on chemotherapy, patients who are on immunosuppressive therapies because of the rheumatological diseases or autoimmune diseases. Okay, so those patients, they can have acute infection to begin with, but because the immune system is not there to contain the infections, so in those cases, even the acute organisms such as E. coli and Shigella, they can get prolonged and they can enter into a bit chronic phase. So patients who are immunocompromised, and then in those cases, we also need to consider all the bugs, including the acute infections, even if the diarrhea is chronic, because we think that immune system failed to contain the infection, right? So, but if the patient is not immunocompromised, then it's very uncommon for the bacterial infection to become chronic, okay, such as E. coli. Chronic E. coli colitis is very uncommon. Same goes with the Shigella, and same goes with the Salmonella and other gram-negative bacteria. But other than the gram-negative bacteria, most of the other organisms, such as parasites, tuberculosis, and the chronic organisms such as Yersinia and Campylobacter, they can enter into the chronic phase. Okay, So this is mainly about the infectious diarrheas. Okay. Now, what we do is the diagnosis basically depends upon where we are standing, which anatomical location we are dealing with. Are we dealing with the small intestine? Are we dealing with the ileum? Are we dealing with the colon? So that will give you the most likely organism. Okay. And this one more important part of the infectious diarrhea is a Clostridium difficile, C. diff colitis. Okay. C. diff colitis commonly happens either because of the antibiotic use or because of the hospitalization even without antibiotics. It's not uncommon. I'm saying it's not uncommon to have C. diff even in the community and even without use of the antibiotic. All this is not as common, but the cases do exist. Okay, so we also need to be mindful of C. diff even if the patient are not having a history of antibiotic use. Hospitalization itself is a risk for C. diff infections, C. diff colonization, and C. diff infection. Same goes with antibiotic use, increases that risk. But just living in the community is also has a small percentage of the cases which can have C. diff infections. Okay. Classically, C. diff mostly causes infection in the left side of the colon. Okay, as a common pattern, it can cause pancolitis, but commonly it infects the left side of the colon, unlike mebiasis, which mostly infect the right side of the colon. Okay, and that's why it's commonly identified by doing a proctoscopy or flexi sigmoidoscopy, and we can see a pseudomembrane and take a biopsy of it as well. So commonly, C. diff colitis it causes left-sided colitis more than the right-sided colitis, unless it's a pancolitis. Okay, so C. diff is an important differential, especially in the patient who present with acute diarrhea and is acute infectious, and especially when there's a colitis. Okay, right. Now these are the infectious causes. Now there was a question about ileitis and other immune causes of ileitis. Usually, among the immune causes of ileitis, they can present acutely, and few of them are very important. One of them is a small vessel vasculitis. Okay, small vessel vasculitis can cause ischemia of any part of the gut. Okay, and it can cause acute ischemic colitis, which can get infection on top of it, and it can also cause acute inflammatory ileitis as well. But more commonly is a Behçet syndrome, which causes inflammation of the ileum and the right-sided colon. Okay, and it can confuse with either acute ileitis or it can confuse with a chronic ileitis. Okay, the rest of the autoimmune diseases, they are less common to involve the ileum, such as lupus or rheumatoid. They are very uncommon. However, the medications we use to treat these autoimmune diseases, such as mycophenolate or leflunomide, they can cause irritation of the ileum and they can cause diarrhea. Okay, so autoimmune diseases, they less likely involve ileum except small vessel vasculitis and Crohn's and Behçet's. Okay, the common autoimmune diseases, they commonly don't involve ileum, but their medication do. Okay, so this is about the main thing you need to know about the infections. Okay, so I would summarize it by saying that if the symptoms start within 6 hours and resolve within 24 hours of ingesting a food, this is preformed toxin. We don't need antibiotic. Okay, just manage symptomatically. If the infections, if the symptom goes beyond 6 hours, 24 hours, then ask yourself where we are standing. Are we standing is the patient having a malabsorption? Then think about bacterial overgrowth, think about giardiasis. Okay. If it's acute ileitis, think about Yersinia, Campylobacter, and Salmonella enteritis. If the patient is acute colitis, think about mebacolitis or gram-negative organisms such as E. coli, Shigella, Salmonella, and also think about the C. diff colitis as well. Okay. The other causes of these uh, non-infectious causes you should also entertain, especially when you have excluded these infections or when the duration has gone beyond 2 weeks and the patient is not immunocompromised, certainly then the non-infectious causes will also come into the play. So that's what I wanted to convey about the acute infectious causes. Feel free to ask any question.
Assalamu alaikum, sir. Sir, then for the first 24 hours, we shouldn't start any antibiotics.
No,
I mean,
if in the first 24 hours there are evidence that the patient is having malabsorption or the patient is having acute colitis, yes, we should.
okay.
So those clues are pain abdomen, blood in the stool, white cell in the stool, tenderness along the colon, and systemic clues such as fever, high CRP, and high white cells. They indicate that there's a damage to the wall. Okay, that is not common with the preformed toxin. Preformed toxin, they don't damage the wall of the intestine. Okay, preformed toxin, they also don't cause malabsorption. All they do is they increase the secretions of the intestinal glands and causes runny diarrhea, watery diarrhea. That's what the preformed toxins do. Okay? They don't damage the wall and they don't cause malabsorption. So if there is evidence of malabsorption or if there's evidence of damage to the wall, yes, start the antibiotic, depending upon what we're dealing with. Is that clear?
Sir, very clear now. Thanks a lot.
Thank you. Any other question, please?